Bismillahirrahmanirrahim. It's my pleasure to be with my professors and colleagues from my country. I was graduated from Ain Shams University, then had my master, then I came here in Latifa Hospital. I had a master in the healthcare management, and I'm in the final stage of my PhD, inshallah. So the good thing, and I'm happy also to be among the Forsaides, because I'm originally from Forsaid. So I'm happy to be with you. I'll present a practical lecture about the outpatient management of the preterm formula. I think most of us are dealing with preterm babies that have been discharged from the NICUs, and but what we should do with them. This is the aim of this lecture. So there is a role in the neonatology which says once the baby is preterm, then he will be always preterm, as we can see in this newly born 24-weekers baby who attended the infant follow-up clinic at the age of 3 months, which was corrected age at term baby. So the objective is to discuss the benefits of follow-up, define who should be followed, define the optimal age and method of the follow-up, and give out the recommendation. It is not our recommendation, it is the one very interesting article by the American Academy of Pediatrics in 2010 discussing the full details about the discharged babies from the NICU. The references, my main reference is the hospital discharge of high-risk neonate proposed guidelines by the American Academy of Pediatrics Committee of the Fetus and Newborn in 2008. So we'll discuss some terms and definitions to know what, how we can build our decision later on. So the preterm infant is an infant who is less than 37 weeks. The low birth weight is the less than 2.5 kilo. The very low birth weight less than 1.5. Extreme low birth weight less than 1 kilo. So what is the chronological age? The chronological age is the time since birth. So if the baby is born at 24 weeks and he is in the unit for 3 weeks, then it is he will be 27 weeks. Post-conception age is the time since the conception, and the corrective age is the correction for the prematurity. We'll come to know by example later on. So who needs the follow-up? Whom do you think needs a follow-up? So those who are less than 1.5, they should have a follow-up to know the progress of the weight, to know the catch-up, to know the neurodevelopmental, their neurodevelopmental status as well. Any medical history or condition of the following: a case of bronchopulmonary dysplasia, especially those who are requiring the oxygen at 36 weeks post-conceptional, especially those who received courses of dexamethasone. As we know, dexamethasone is having a deleterious effect on the bone and on the neurodevelopment of the babies on the long term. Any babies who had a neck with surgical intervention, and here the idea is those babies are more prone for short bowel syndrome and they need a special referral to gastroenterologist. IVH grade 3, 4 or periventricular leukomalacia, abnormal neurological examination at the time of discharge, seizures related to the IVH or asphyxia. Cases of meningitis, any patient with HIE that required cooling therapy, the hearing of or vision deficit like ROP related to the prematurity, persistent pulmonary hypertension, that required at the stage high frequency or nitric oxide. In the case of pathological jaundice that required exchange centrifusion, and again the idea of this because we are concerned about the level of the serum bilirubin and the possible deleterious effect on the brain and development of carnitines. Why we are following this? Because there is a risk of disability in the preterm group. The following is an estimate of the risk of disability in the infant with birth weight less than 1.5 kilo. So less than 1.5 kilo, they are having mild to moderate disability with the incidence of ranging between 8 to 57, which is a big difference, and a severe disability up to 20%. The most common disability is the mental retardation, then comes the cerebral palsy, blindness, and deafness. For this, a psychomotor testing, which is really deficient in our follow-up clinics, and we really want to concentrate on having a proper psychomotor testing using different tools such as the Denver tool, and the more important for us is the Bailey scale of infant development that are helpful for the identifying the babies at risk. So what is our discharge planning? Most important that the care of each high-risk baby after discharge must be carefully coordinated with the providing ongoing multidisciplinary support of the family. That means if I'm a doctor in the NICU and I know that this baby is going to be discharged, I should coordinate with the doctor who will follow up this case to inform him that this baby is preterm, he was subjected to oxygen, he had nitric oxide, so I should give him a full detail about the history of the baby. So the discharge planning team should include whom do you think having a role in the discharge plan of a preterm baby? كله. Parents, neonatologist, neonatal nurse, primary care physician, and social worker. بس كده? No, we're having other teams that might be involved, like the surgical, pediatric subspecialties, pediatric occupational therapy, physical, speech and respiratory therapy, infant educator, nutritionist, home health care liaison, which is deficient in our area, and the case manager that will help supporting the parents, which is very important for the continuation of management and follow-up of the baby, because so many people, they will not go for follow-up because of the financial issue. As you mentioned, the discharge plan differs depending on the history, whether the preterm baby came, he had nasal flow only, rather than the baby who had high frequency ventilation or nitric oxide. The goal of the discharge plan is to assure successful transition to home. The initiation of the discharge planning should begin when it is evident that recovery is certain, although the exact date of the discharge may not be predictable. So whenever we are having a preterm baby in our unit, we will start since admission involving the parents in our discharge planning. So the discharge plan is done since admission. It is not at the day of admission. So the essential elements, when I will discharge those preterm babies or high-risk babies, when they are physiologically stable. When we should administer the immunization And the immunization schedule should be given to the parents. It is recommended now the use of palivizumab, which is RSV immunoprophylaxis, especially for those babies who had chronic lung disease, those with the cyanotic heart disease. They are prone for readmission to the hospital with its financial drawback on the organization and the parents themselves. Vision and hearing screening and neonatal screening. I don't know whether in Egypt they are following the neonatal screening or no?
Screening
neonatal. هو الميتابوليك screening.
Only for thyroid or
thyroid.
Some university hospital metabolic screening.
هيطلع في الكيتونوريا قريب يعني.
اوكي. Whenever we discharge, we should also see the family who can provide the necessary care and the primary care physician who is prepared to this responsibility. I know in our culture, most of the neonatologists, they will continue following their babies. But in the area where the parents are moving from one place to another place, the discharge summary with the full details of the case should be handed to the parents. Special care needs that for cases of chronic lung disease or BPD, and they are BPD oxygen dependent, they can go with oxygen at home and inform the parents about the maintaining the oxygen saturation little at or above the 94%. Infant who had bowel resection, they should have a follow-up with the pediatric gastroenterologist, as I mentioned, because of the risk of the short bowel syndrome and the need for long-term parental nutrition based on the segment resected. The parent requires instruction to the care of central venous line in case of need for the parental nutrition. The discharge planning based on this recommendation from the American Academy of Pediatrics is having 6 steps. In our culture, we usually go to the 3rd step, and we need a better follow-up for the other 3 steps. So parental education, as I told you earlier, the parental education starts from day 0. So once the baby is admitted to the NICU, the parents should be called, interviewed, and the possible outcome, possible management should be discussed with them. So, parental contact and involvement in the neonatal care should be encouraged from the time of admission. We should have time to sit with the parents, and it is not only on admission and that's it, on a regular time to update them about the follow-up and management. The participation of the parents should be as early as feasible. It has a positive effect on the confidence of the parents, especially the mother, because so many mothers think that the preterm babies and its complication is her mistake. So based on this, we should remove this feeling and give her the confidence in the handling and readiness to take care of the responsibility of her baby. We should encourage the parents rooming in and the telephone follow-up. So
in Egypt
it's difficult, but it is of beneficial effect because there is a study and it is published in 2012 about the results of the babies who had a roaming in as compared to the babies who didn't have a roaming in, and it was clearly that all the parameters with the roaming in is better than the babies who didn't have the roaming in care. This we discussed it. Coming to the second point is the implementation of primary care. So the follow-up with the primary care physician should be scheduled. Direct communication between the discharging physician and the primary care physician before the discharge. And as I told you, if the parents are going to be discharged, they should be handled a full detailed discharge summary till the day of the discharge. We advise that if we are going to discharge a preterm baby, we don't discharge the babies on the weekend. Because on the weekend, first of all, the staff are less because of the holidays. The staff is busy, the one who is on call is busy, and he wants to finish his work, so he might forget important issue in the discharge. So in such a case, we would recommend discharging in the weekdays, especially the infant with the special need. The major goal of the pediatrician, of the family physician providing the care, is to provide the ongoing assessment of the growth and nutritional intake. So if I'm the primary health care physician, my role is to take care of the growth and nutrition, deliver the preventive measures such as the immunization, and perform the neurodevelopmental assessment, which is really lacking in our culture and area. Growth assessment, the healthy low birth weight, who are AGA, experience catch-up during the first 2 years of life, as all of us know. The growth parameter should be plotted on the standard curve according to infant adjusted age. The adjustment should be done up to 2, and some of the literature are telling adjustment should be done up to 3 years, because there will be no major difference after the second year of life. After that, the difference is insignificant. The growth pattern is valuable indicator for the infant well-being. So we'll have an example for the correction of prematurity. A baby born at 26 weeks, that is premature by 14 weeks. So now he is seen at 1 year in the clinic. So the chronological age is 1 year, because this is the time since birth till the date who have seen in the clinic. So I need to plot the weight and development for 8.5. Okay, so this is the correction, because all this is intrauterine time. This is 14 weeks intrauterine. So the correction is since the expected date of the delivery. The pattern of growth is important to evaluate the weight gain, and comparing the gain in the length as well. The low weight for length indicates inadequate nutrition. So this is very important, that I should take the weight and I should take the length and plot the weight against the length. The primary health care physician must be alert to the signs of growth failure, and particularly the emphasis on the head growth. Babies who had perinatal asphyxia, babies who had courses of dexamethasone, they should have a head growth follow-up to predict the future outcome. The head growth is usually the first parameters to demonstrate the catch-up growth, and the rapid head growth must be distinguished from the pathological growth caused by the hydrocephalus. So we should differentiate between the catch-up growth of the baby and the hydrocephalus that can happen due to either severe IVH or obstructive hydrocephalus. Second condition placed the infant at risk for growth failure, such as chronic lung disease, perinatal asphyxia, IVH, as I mentioned, congenital heart disease, short gut syndrome, renal disease, inborn or chromosomal disease. There are different charts for different ages and sexes, and this is available on the WHO website. There are special charts for the Saudis, and I think we in Egypt are having our special growth chart as well. Nutritional requirements of the preterm infant exceed the need for the term at the same adjusted gestation age. Increased need may persist for the first year. Chronic disease greatly increase the caloric requirement. So the more the preterm and the more the chronicity of the disease, then the more the caloric needs. So in healthy preterm baby, he needs 110 to 130 cal per kg per day. It can be increased in cases of chronic lung disease, reaching up to 200 cal per kg per day. More than 24 cal formula can cause hyperosmolar dehydration, so it is not recommended outside the hospital. Inside, it can be given to promote the weight gain, because we can follow up the sodium and the early signs of hyperosmolar dehydration. Solid food should be introduced at 6 months corrected age. Preterm formula designed for preterm, which is having less than the 24 cal, and it can be used at home. This formula is intermediately between the preterm formula and the term, and contains 73 kilocal per 100 ml. Although the use of PDF is based on the sound nutritional knowledge, but in the Cochrane 2012, they are telling there is no difference between the PDF, and hence the milk company had a great drop in the PDF after this Cochrane review. Coming to the next point is the neurodevelopmental outcome. The neurodevelopmental outcome is recommended to be done as a part of all examination. Whenever we're having a follow-up of our case, we should do the neurodevelopmental outcome. I know it is difficult in practice to have this in each visit, but at least it should be done at 4 weeks, 8 weeks, then 3 months, 6 months, according to the guidelines in this from the American Academy of Pediatrics. We should assess the muscle tone and the flexes, referral to the therapist as appropriate, review the milestone related to the corrected gestation age. So if a baby who is 1 month chronological age, I will not see his milestones as compared to the 1 month, but I'll see his milestones according to the 8.5 months, as we mentioned earlier. What is the difference between the preterm and term formula in tone is should be also evaluated. Most preterm formula, preterm infant will experience delay in the developmental. This is due to the prolonged hospitalization, impact of medical condition. So the impact of prematurity without neurological insult lessen this overall. The developmental proceeds from head to toe and proximal to distal. We should see the motor skills, both gross and fine, the language skill, social skill, cognitive skill, and adaptive skill. As I told you, these are the tools for the infant developmental, which is the Bailey scale for infant. It was developed in US, validated in the UK. It is beneficial for the age between 0 months to 42 months. It assists the cognitive skill, motor skill, both fine and gross, and language, both expressive and receptive. So it is very important to be used in our clinic, or if it is not, then I should refer to the concerned department. This is the bag or the tool for this Bailey scale. The other scale is the Griffith scale, which is developed in UK, validated in UK and South Africa, starts from age 0 to 8. It is mainly concerned with the locomotor system related to the social, personal, hearing, language, hand and eye performance, and practical reasoning. This is the website for those who are interested to have more details about it. And this is the tool to assess the Griffith scale for the neurodevelopment. Denver is another tool. We'll go for the immunization. Preterm should be immunized usually at the usual chronological age, so not to miss any vaccination. Vaccine should not be reduced for the preterm, because so many are telling this is preterm, so I will not give the same dose as the preterm, I will reduce the dose. So the dose should not be reduced. We should follow the American Academy of Pediatrics guidelines or the country specific. We mentioned that RSV or respiratory syncytial virus is the leading cause for rehospitalization under the age of 1 year, and the risk factors: day attendance, school, sibling, and lack of breastfeeding, multiple births, passive smokes, births within the 6 months of the RSV season. We only have one vaccine, which is the Synagis. It is monoclonal RSV antibody. It is immunoprophylaxis. It is not vaccine. It is administered in the dose of 15 ml or 15 milligram per kg intramuscularly. The recommendation now, based on the Canadian Academy of Pediatrics, to start the doses starting from the September rather than the American requirement of starting at October.
That dose is not covered by insurance, right? Very expensive one.
I was in a conference in Ras Al Khaimah 3 weeks back,
Okay.
and they are telling that 3 companies of insurance, one of them, Daman, is covering the RSV.
Yes.
It's
Oman
covered.
or Daman?
Daman.
Daman.
Daman is the most common
Okay.
public insurance here, and Daman is covering at the
انا
beginning
سمعت
they
ان
were.
الروتا فيروس اوريدي هيبقى انكلودد في دي اتش اي، خلاص هيبقى فري. هو في ابو ظبي بقاله فتره، مش كده؟
هو اوريدي على الليسته.
على الليسته. انما الار اس بي
Already
لسه
على
دلوقتي
لا بس ال RSV يعني originally they were covering only the Emiratis. Now they're covering everything. And cost effective.
الاسبوع اللي فات احنا دخلنا الهروب اتش اي بي
لا والله
اول مره بعد 25 سنه. فيرست تايم في جفرمنتال ستيت. بنتكلم في ريسبيرس سيشن. خايف ان احنا
قريبا ان شاء الله.
ربنا يسهل.
Again, an important issue is the hand washing. Hand washing and hand washing, it's very important. Whenever you touch the baby, before and after touching the baby, you should wash your hands. And they did the statistics on the hand washing, and it was having a bad result interpretation for the doctors, because the most complying were the nurses and the least complying were the doctors. So imagine the physiotherapists are coming, hand washing before and after, the nurses before and after, but the doctors are having incompliance in this. We had it in our organization. Hisham, you are having the same?
Yeah.
Doctors?
That is international figure.
It depends who is watching.
Okay, sanitizers is enough, yes. But you should do it before and after each baby. This is the issue. So,
Fin, which hospital?
I will run through the rest of the recommendation because mostly in our culture we are not going through. We should review the hospital course and take a program list of each patient. We should carefully assess the physical assessment revealing the physiological function that have not reached for the full maturation of those babies, developmental of home care plan, and we wish one day to have it in our country that a team from the doctors and nurses and the psychologists and social worker will go and visit the patient at their place, listen to their requirement, and help them in their problems. Identification of mobilization and surveillance and support service again is the social support requirement, and finally the determination and designation of the follow-up. Primary care physician, as I mentioned, should be identified as early as possible, should be involved in the management as early as possible, and should meet the parents before the discharge and if possible examine the baby. So I can request him to come to my place and do this examination. So at the end of this lecture I'm having final thoughts. Patient experience among others, they feel the guilt, fatigue because they keep on shifting and alternating between the father and mother to visit the baby. The anxiety and emotional disturbance, especially the baby is transferred to the intermediate care and they are there, and on the next day they will come and see the baby in the intensive care. So this will cause an anxiety and emotional disturbance for the parents. Important issue is the financial difficulties. I know it is in our country available, and we face it here because now the non-local are paying for the treatment, and we face so many families are telling we don't any further management for our baby, we cannot afford the treatment. Lastly, yesterday we had the baby mother who is para 6+0 delivered at home. The baby was asphyxiated for 1 hour, and they were discussing, the father and mother, to bring to the hospital or not, and to have the risk of payment or not. The parents may be left with less obvious emotional difficulties due to having an NSU graduate if they are involved in the decision and involved in the care. As the primary care physician, it is important to understand that feelings and to support not only the patient but the family as well. It is important to know where to refer these families if they need more support. The correct growth and development for prematurity, give the immunization on time, nutrition, and early recognition and intervention. The thought of the day is my best year of life, that when I was between the lap of a woman who is not my wife. صح؟
وجهة نظر يعني.
ده جديد. Okay. So this lady is the mother. Okay. where kangaroo care is encouraged, and this will help both the having the smile of the mom and improvement of their psychological status, also the feeling of the preterm, even he is intubated and ventilated on his mom breast. Okay? It is not okay yet, because kangaroo care also can be given by the fathers, and it will help also in bringing the father to have a role in the management of his preterm. Thank you very much, and also I would like to invite you for the third International Arab Medical Congress with the first MIMAP update on pediatrics in collaboration with the American Academy of Pediatrics. It will be in September 2014 in Dubai. So welcome all of you, and thank you very much.